Okay, everyone. So, my name's Dr. Ted Everson. I'll be co-presenting and facilitating today. Just in terms of an outline for today, we have an hour set aside for the webinar. We'll do initially around 45 minutes of a slide presentation. We'll leave 15-20 minutes at the end for questions. In terms of your questions, you can either save them until we're done the slide presentation part, or you can insert them in the chat and we will try to either answer them real time or close to real time, or we'll track them and save them until the question period. In terms of speakers today, myself, I'm a medical advisor at the CPSO. I work and support our quality programs. We also have my medical advisor colleague, Dr. Mary Manno. We have Ms. April Jacobs, who's the manager of our quality programs. She'll be supporting and helping to facilitate the questions that you submit. And as well, we have a guest speaker, Dr. Paul Hendry. I'll see if Dr. Manno, do you want to introduce yourself, Mary?
Sure. Yep. Thanks, Ted. Hi, everybody. Thanks for joining us today on this very warm day. We are really pleased to have the opportunity to talk with you about the Quality Improvement Program. I'm a family physician by training, and I've been with the CPSO for a couple of years now, working in the program in the individual stream. And we'll talk some more about the different aspects of the program as we go along. Thanks, Ted.
Great, thanks, Mary. And just another housekeeping item, we will be recording the webinar and it will be posted and viewable as a reference later on. We will have a link on our website under our quality programs, and as well, all previous webinars will be posted to the CPSO YouTube page, so you can reference it in the future. In terms of the learning objectives for today's webinar, so Dr. Manno and I will go over the college transition from a quality assurance approach to a quality improvement approach. We'll review the CPSO tools that we have available for self-directed quality improvement for physicians, and then we'll provide an overview of the new quality improvement program options that are available that physicians can participate in to meet their quality requirements with us for a 5-year period. As well, as I mentioned, we have a guest speaker. Dr. Hendry will be speaking on the University of Ottawa program, their physician practice improvement program that can support physicians in doing quality improvement. I'll give a little bit of background on our guest speaker at this stage, and then Dr. Hendry will present following the CPSO piece of the presentation. Dr. Hendry has been on council at the CPSO as the academic representative for the University of Ottawa, and is currently the Vice Dean of Continuing Professional Development in the Faculty of Medicine at the University of Ottawa, and he'll be speaking about the essentials for practice improvement for Ontario Physicians Program that they have available. I'll start with some background on the CPSO and our journey with the redesign of our quality programs. So as you may know, at the CPSO, we have undergone a significant redesign of the quality program options available for physicians. Historically, the majority of physicians had participated in our random peer assessment program, and that had been in place for decades. Based on our experience with the peer assessment program and based on the known benefits of quality improvement, we did undertake a significant redesign of our quality program options and introduced options that have a quality improvement basis or strategy that are available for physicians. In terms of a couple of the key principles that we base this on, we certainly want to engage and have meaningful engagement with our physician members, and we want to support physicians in providing high quality medical care. Another principle that maybe you're not as familiar with is something called right touch regulation, and right touch regulation is a core principle that we utilize at the CPSO that helps to guide the work that we do in many different areas and not just within our quality programs. So whether it's within registration, whether it's within our investigations and resolutions program, policy development, we try to utilize something called right touch regulation. And what right touch regulation is it is really a framework or an approach to determine the appropriate level of our involvement in a particular matter or in a particular area. It's based on an evaluation of risk, and it's intended to be outcome focused. And again, this was in addition to the shift to quality improvement, we used right touch regulation as a guiding principle to the redesign of our programs. As mentioned, background in quality at the CPSO. All members must participate in one of our quality programs. This is within the quality assurance regulation. Historically, this was through our random peer and practice assessment program that had been in place for quite a long time. And most physicians, the intent was to have a peer assessment approximately every 10 years. Again, based on our experience with the peer assessment program and based on some emerging and developing literature around the benefits of quality improvement, we decided to redesign and change the program options that we have available to physicians and have adopted a QI basis to the programs. Now, certainly peer assessment still exists and remains an important tool for our committees. An example would be our age-related peer assessments that start for physicians at age 70 and are on a 5-year interval. When we looked at our experience with peer assessment, which is really an audit-based or quality assurance approach, we had been doing approximately 3,000 peer assessments a year. And in 90% of those, there were no problems or issues that were identified. And in fact, in the 10% that were, many were low risk or low level concerns. Based on that experience and based on feedback with the process and experience by the participating physician, we felt that we could achieve more value and more impact and a more collaborative relationship with our membership by transitioning to a quality improvement approach to our programs. This slide outlines the potential benefits with a quality improvement approach versus a quality assurance or audit-based approach, and this is consistent with our experience at the CPSO. With quality assurance, there's really an impact or action for a small number of individuals when you're assessing to meet who is meeting a minimum standard. Whereas with quality improvement, when you do that process and apply it to a group that is practicing at a high level, there still is the potential for everyone to change and improve. And therefore, there's the potential for a bigger impact or shift on overall quality. This slide, again, is a comparison with the two approaches. Quality assurance is an audit-based approach where we have a peer assessor conduct a practice audit. It looks at care that's been provided in the past, and it's really verifying and assessing if someone is meeting a minimal acceptable standard, which in the case of our peer assessment program, the vast majority of physicians were certainly doing that. Whereas with quality improvement, this is a self-guided process of learning and measuring. We do offer coaching, and Dr. Manno will speak to that in the context of the Quality Improvement Individuals Program. And this is looking at the impact on care that is yet to be provided. And with that, I will pass it over to Dr. Manno to present on our current state and the Quality Improvement Individuals Program.
Thanks, Ted. So when we're looking at our QI program, our goal is to be in touch with every physician in Ontario every 5 years. And this includes a number of specialties who weren't previously brought into the peer assessment model. So it is quite a change for all of us. And this being our first go round, we're also working on our own quality improvement as we proceed with the program. I think to begin, it's important to recognize that the program consists of 2 streams. One stream is called QI for individuals, and it has a subset called groups. The other stream is QI partnership. The partnership stream has been developed to engage hospital-based physicians in QI, and that is the area that Dr. Everson leads, and he's going to be speaking about that specifically. I'm going to go on now to talk a little bit more about QI for individuals. Next slide, please. So the QI for Individuals program was piloted in 2019 with 260 brave family physician volunteers. And by 2020, we had been able to roll out to 1,700 family physicians. We started with the family physicians because they represent the largest cohort of our members. In 2021, 6,000 members were invited, and these were also family physicians, but also many other specialties, as we've listed here. And in 2022, we have 4,000 members invited specifically to QI for Individuals, and we also have now operating the group subset, which I'll come back to in a moment. And I just want to point out that members who being invited in 2022 come from a variety of practice settings and specialties. It is possible for a hospital-based physician to participate in the individual program. There is sometimes some overlap. We can talk some more about that if those are interested. Next slide, please. So the individuals are going to be involved in the program in a 5-year cycle. And the way this works is the program is presented online and accessed through your own portal and by clicking on your QI tile. And again, we can come back to this if people would like some more specific information about the online aspect of the program, the technical aspects. But important to know that there are 3 activities embedded in the online program: practice profile, self-guided chart review, and data-driven QI. And these activities have been designed to allow the member to look at their own risks and strengths and weaknesses and assist in self-assessment that will allow you to identify your own strengths and set a couple of SMART goals that can be then incorporated into the practice improvement plan. And that's the piece that's submitted to the college. I think this is an important point to just ponder for a moment. The 3 activities that I mentioned, practice profile, self-guided chart review, and data-driven QI, we do look to see that those have been completed. However, the content of those activities remains private to the individual in order to permit self-reflection and an analysis of your own strengths and weaknesses. So once members have a sense of what areas might potentially be up for improvement, those then can be incorporated in the practice improvement plan, which is also provided online in a format that asks stimulus questions. So I think it's fairly easy once you have an improvement idea in mind to incorporate that into the format online. The practice improvement plan, we call for short a PIP, and the PIP is designed to include a minimum of 2 and a maximum of 4 improvement goals. And one of those goals can be relating to physician health and well-being, which is a pretty important topic at this point in time. So I think that's a great opportunity for us. Once the practice improvement plan is submitted online, it is reviewed by one of our 10 QI coaches, and each member will receive written feedback pertaining to their practice improvement plan. Next slide, please. So, question that I'm asked quite often: where do these improvement goals come from? Like, do they just materialize from the air? Do they come from the Cabbage Patch or what? So what I've tried to do is just take a few examples to illustrate how some folks have approached this. Next slide, please. So in relation to the practice profile activity, for example, this is a member who says, I'm a solo physician over the age of 60. Before completing this QI activity, I did not appreciate the impact on patient care, and I had no idea that I was at increased risk of a college complaint by virtue of his practice profile. So my goal for improvement is to mitigate this risk and obtain collegial support for my practice of medicine. So he's starting out with the current state or a baseline of little or no peer support. The intervention that this member has in mind is to rejoin his problem-based small group by contacting the Foundation for Medical Practice Education And he's also thinking about and planning to apply for affiliate privileges at his community hospital. And he's asking for an invitation to his local family physician WhatsApp group. Those are the interventions that are going to help him achieve his goal. His outcome measure, which is a reflection of the future state, is in 3 months' time, I will reevaluate my level of peer support. And so this would be an example of an improvement goal that could have arisen from an individual member's practice profile activity. Next slide, please. With regard to the self-guided chart review, this is an opportunity for the member to review 5 charts that reflect the types of patients that one sees on a day-to-day basis and use a checklist which is provided to assess the quality of the record keeping. Now, it's fair to say that there are many physicians in Ontario who practice in a role that doesn't necessarily involve direct patient care, and they may not have the types of charts that I would keep when I was a comprehensive family physician. And so in some cases, the materials still need to be updated, and we here at the CPSO are working on that as part of our ongoing QI. However, in the meantime, if you're in a situation where you're not sure how to use how the self-guided chart review activity applies to you, it is permissible to just skip the areas that don't apply to you, mark them as not applicable. Because remember, these materials are for your own use and self-reflection. So they may be more relevant to one practitioner than they are to another. And I should say, if you ever have questions about how to approach this, or you're wondering, I'm available to meet with members to help guide you through these activities and through the whole process. So that's always an option for you at any time as you participate in the program. So getting back to self-guided chart review and the ways that online activity could stimulate finding an improvement goal. This is a person who, when we went over the results of my SGCR, my trusted peer noticed that I often neglect to include negative findings in the record. For example, a 65-year-old smoker should probably have an indicator that the abdominal aorta was not palpable when they're presenting with abdominal pain, for example. So the current state for this member would be, when he did his chart review, he realized that 3 out of 5 charts did not include significant negative findings. The intervention that the member chose was to set a reminder, could be electronic or some other kind of reminder, to document negative findings. And his outcome measure is to conduct another chart review after a period of 3 months and reevaluate the number of charts that include significant negative findings. And I should mention before we leave this slide, the concept of the trusted peer. That's a colleague who knows the way you practice and obviously what a medical record should entail, who can give you some feedback on your self-guided chart review so that there's an element of objectivity as well as your own subjective assessment of your record keeping. Next slide, please. When we're thinking about the data-driven quality improvement activity, this is an opportunity for us to learn about the types of data that many of us have pushed to us and maybe aren't even aware of. And I have to say, in family medicine, we're very fortunate to have lots of data being pushed to us. Some of our colleagues not so fortunate, and so we have to be more clever about finding data that can be used for improvement purposes. And I'm going to speak to that in a moment. So for this member, I had no idea all that data was being pushed to me. I can use my screening activity report to create a goal. That is commonly referred to as a SAR, and it is a report that comes from Cancer Care Ontario to rostered family physicians in order to give feedback about preventative care in relation to Pap tests, mammography, etc. I can embed the I4C dashboard into my EMR. Ontario MD is working hard to help optimize the use of EMRs, and this can definitely be leveraged for QI purposes. In relation to other physicians who may not have data being pushed to them, that's okay, data can be pulled. I can observe my own practice and think about the pebble in my shoe, that little nagging thing that bothers me as I'm proceeding through my workday. So I'll give you some examples. One would be, I'm a therapist. My counseling sessions run late 50% of the time. So we can see how that person could structure a goal around completing counseling sessions on time at more more reproducibly. Another example would be, as a specialist, patients have to wait 2 months to see me in consultation. That physician might structure a role about reducing waiting time. I'm a locum. How do I get feedback on my performance? That's an interesting point that we could happily come back to later on in the discussion. 25% of my patients prescribed opioids may benefit from deprescribing. That could be a good goal. As a radiologist, I review about 10 interesting or challenging cases per week, but receive little or no feedback on patient outcomes. That member actually did structure an intervention to elicit feedback from referring physicians, which was really interesting. Next slide. We talked a bit about physician health and self-care, and this is such an important topic given that what we've all been going through the last few years. This person looked at the CMA resources and realized that they could structure a self-care goal for him or herself. And examples of that could be, I'll leave my office for 30 minutes at lunchtime, at least 3 out of 5 days per week, go for a walk, do something, eat lunch, etc. My staff really liked it when I did this goal because that meant I didn't talk to them for half an hour. Another example will be, I'll keep track on a calendar, a check mark for each day that I succeed, and after a month, I'll count my successes and reward myself accordingly. So this could actually comprise one goal. Next slide, please. When we look at all the practice improvement plans that are being submitted to us for review, the vast majority are very good and meet all the requirements and the criteria that are set out in the program. However, the odd time we will see QI goals that need further development or enhancement, and we do have an opportunity for coaching. And my estimate would be that that around 15 or 20, even 20% of PIPs are currently being offered coaching in order to assist the members in developing their goals further. And this could be in relation to clinical care or practice management or wellness issues that were identified during the review of the PIP. Next slide, please. Now, an exciting thing that's happened this year is we have rolled out QI for individuals group subset, which means that an individual member who has been invited to participate in the program can invite up to 6 colleagues to participate as a group. Those colleagues don't have to have been invited, but by virtue of being included in the group, they will then be able to meet their 5-year commitment or requirement at the college by participating as a group. Next slide, please. So in 2021, we piloted this process with 4 groups, and in 2022, so far, we already have 86 groups participating. Most of the elements of the program remain the same as QI for individuals. Each member of the group is still required to complete the 3 online activities that I referred to a moment ago. But the difference is that the physicians submit a group PIP instead of individual PIPs. So obviously, this is going to require some collaboration as members talk about opportunities for improvement that affect each member of the group and would be meaningful and relevant for each group member. Next slide. And I think I'll stop there now. There may be questions which we'll certainly be happy to address at the end. I'm going to turn it back over to Ted now, and he's going to talk about the partnership side of the program. Thank you.
Great, thanks, Mary. So I'll provide a fairly high-level overview of our other QI program stream called the QI Partnership Program. So just a reminder, this is the current state of our QI program options, individuals and group subset that Dr. Manno spoke about, and I'm going to speak about the QI Partnership Program, which is an option for physicians that practice in a hospital and are interested in doing QI as a group with their colleagues. Again, the strategy and the vision of the partnership program team is really wanting to engage physicians in doing quality improvement. And in the context of the partnership program, we're hoping that this can support important hospital priorities or important things that are relevant to your own clinical environment. We certainly recognize that in the hospital setting, many physicians are already participating in various quality activities. And with this program option, there's certainly an opportunity to recognize that and avoid some of the duplication that exists with the various requirements that we have as practicing physicians. And again, this loops back to wanting to engage physicians in doing QI and how it can be an important way to change or improve clinical practice. For the QI partnership program, what it really is then is it's a program for physicians to participate in a hospital quality improvement project with their colleagues. And by doing that, they will be eligible to meet their CPSO quality requirements for a 5-year period. Physicians will be required to do 2 of the online quality improvement activities that Dr. Manno had walked through. And again, the vision is that the QI initiative will support something that is important or relevant to their organization's strategic plan or quality program. In terms of what hospitals and groups can do, the bottom line is that the design and the nature of the QI project or initiative is quite flexible. A couple important considerations. Certainly, I would align a project in terms of its scope and requirements to the resources that you have available. So depending on existing quality improvement expertise or resources or protected time, to design and submit an initiative that works and is feasible for you. Another important consideration is, if there is something that is relevant and important to the current climate. So maybe there is a quality metric that you want to focus on, maybe something like accreditation is on the horizon, and you know that you need to have physician engagement to work on an important initiative. This is a program and this is an option where you can do it in the context of a QI project, and the participating physicians will receive credit and meet their CPSO requirements. Now, in addition, we do have alignment with the Royal College and with the CFPC, and physicians that are participating will be able to concurrently claim CPD credits in addition to meeting the requirements at the CPSO. In terms of the process and the proposal, so we do have a proposal document that organizations and hospital groups will utilize to submit a proposal to us. It follows a fairly standard QI project charter, so outlining a problem statement, having an aim statement, defining this, what's in scope, what's out of scope, and really trying to outline how physicians that are participating are reflecting on the nature of the project and any related data, and as well as having the opportunity to provide feedback. So really outlining the engagement of a physician that's going to sign on and participate. Some examples. Here's 3 examples of approved partnerships that we've had submitted to us. One is from Casey House, a specialty hospital providing HIV care and services. They have submitted 2 QI initiatives. One was related to targeting a reduction in unsigned physician orders, and another was looking at safety around opioid prescribing. I'll share a couple results of how they've been successful with that on the next slides. Another example would be from our partnership with the Collingwood Hospital, and they had submitted a physician wellness initiative where they brought in the self-compassion training for healthcare communities program, which is an evidence-based health and wellness program for healthcare professionals, and it involved the utilization of trained facilitators. Another option was, or examples from Kingston, where it was, it's a multi-site organization that submitted 2 QI initiatives as part of their partnership proposal. One was looking at resource utilization, and the other was looking at a physician wellness program as well. Just further along the Casey House example, and they submitted the 2 initiatives. This was looking at reducing unsigned orders, and this slide outlines the QI process that they followed and how they implemented their project and the positive impact and result that this initiative has had on the reduction in unsigned physician orders. It was really, really well done. As well, there was a safety related initiative looking at clarification and information around opioid prescribing. And again, this outlines kind of the QI process that they followed and the positive results and impact that this initiative had. So with the partnership program, just a summary of some of the key messages and benefits. For participating physicians, we're hoping that this will actually reduce some of the redundancy in the various requirements that we all have as practicing physicians. By participating on a QI project, you'll be able to meet your quality requirements with the CPSO, as well as concurrently claiming CPD credits. For organizations, for hospitals, we're hoping that you can utilize this program as a way to drive relevant quality initiatives and promote physician engagement on important projects and initiatives at your organization. And I will pass it back to Dr. Manno to provide some more information and context on the program options.
Thanks, Ted. This slide is our attempt to compare and contrast the various activities that are required depending on which part of the program a member is involved in. So if we look down the column on the left, if you're in QI for individuals, then you're going to be completing QI survey, which is basically a description of your practice, plus the 3 online activities, which are for your self-reflection. And then the piece that gets submitted is the practice improvement plan. And I should have said when I spoke earlier that the requirement here is for the practice improvement plan to describe fully your plan to improve. The plan itself does not have to have been completed by the time of submission, because you can imagine if your goal is to increase your rate of PAP testing, for example, that could take 18 months to achieve or longer. So what needs to be completed is the plan. It may be that in the future, as the college's program evolves, we will have a component where we will be able to come back and assess the outcomes of the practice improvement plans. We're not there yet, but we're going to be, so keep your data. Having said that, if you're within the QI for individuals part of the program, but in the group subset, you're still going to be completing the QI survey, the 3 online activities, but you're going to be completing only 1 group practice improvement plan that is submitted by your QI lead member. And in the case of QI partnership, practice profile self-guided chart review are still completed individually by the participants. However, the hospital QI initiative is a proposal that that goes forward as a group. And the other piece, sorry, Ted, the peer and practice assessment, which falls within the quality assurance realm, requires a physician questionnaire and an on-site practice assessment. So that's a totally different process that at this point is aimed basically at those over the age of 70. Next slide, please. So our experience to date in QI for individuals, we engaged with approximately 5,000 members since 2019. New this year, 86 groups have self-formed. Each year, more specialties will be invited to participate. And ultimately, if you need a medical license in Ontario to do your job, you can expect an invitation. There will be flexibility to choose the preferred deadline for completion to allow for some choice there. In QI partnership, to date, we have 35 hospitals who have QI proposals that have been approved, organization-wide and department-focused proposals. And this is also comprised of large hospitals as well as smaller community-based hospitals. Next slide, please. So overall benefits of the QI approach. For the member, this is an opportunity to reflect on your practice, set goals that are meaningful and relevant to you, and also earn a whole pile of CPD credits, whether that's from the CFPC, the Royal College, or MD-PAC. And for the college, this program is allowing us to have more frequent contact with physicians. Ultimately, we anticipate a broader impact on quality of care and a benefit in terms of public safety. Next slide, please. So at this point, I'd like to introduce our guest, Dr. Paul Hendry, who, as you know, is from the Faculty of Medicine at U of O, and he's going to talk to us today about a wonderful opportunity for those of us who did not have the opportunity to study quality improvement in our curriculum, now have some other options here. So I'll hand it over to Paul.
Great. Thank you very much, Mary, and thanks for the opportunity to present our program to this group. I just start off by saying this is a collaborative between the University of Ottawa CPD office, the University of Ottawa Department of Family Medicine, as well as Ontario MD. And I'll describe the components as I go through this. So next slide, please. So many might still be scratching their heads about QI. QI, quality improvement, has been in industry for many, many decades, and to healthcare for the last 20, 30 years or so. And it was focused very much on patient safety, trying to reduce harm in hospitals and other healthcare facilities. And more recently, in the last decade or so, the government has used it also as an opportunity to consider how we can improve efficiencies and potentially drive down costs of a very expensive healthcare system. So to that end, a program was developed, funded by the Ministry of Health through the Institute for Health Policy and Management Evaluation at U of T. And this was the IDEAS program, the Improving Driving Excellence Across Sectors, which was a two-day course that was developed based on the model for improvement, which comes from our colleagues in the U.S., the Institute for Healthcare Improvement. And it's a very nice model. It adapts very nicely to healthcare. And this program was delivered by the university CPD offices, the 6 offices across Ontario. And the idea behind it was to provide essentially quality improvement vocabulary and tools to the team members who are participating in larger QI efforts. So we were able to include about over 3,000 healthcare providers across all the different sectors. And it was a very successful program, but unfortunately, the subsequent government decided to put its emphasis elsewhere. But the CPSO has a very timely change from QA for the reasons Ted explained to QI for licensure. So this is something we're going to have to be doing prospectively. And it's very broad in terms of its base, in terms of what you can actually improve, as Mary has spoken to you about. So our CPD office, who had been delivering the IDEAS program, partnered with Ontario MD and Family Medicine to deliver this program, and I'll explain that shortly. So next slide, please. So we looked at the needs of the group who were coming through CPSO, and we came up with the following objectives. So by the end of the program, the learners should be able to develop their QI practice plan. One of the major hurdles is often people find trying to figure out their data sources. As Mary alluded to, most of us were never trained in QI, and it's only been recently adapted into the curricula of all the medical schools and residency programs. But many of us who are practicing don't really know too much about how to actually do it. So it can be scary for some. So once we help with the data, and that's when Ontario MD can provide support in between sessions, then you are enabled to identify areas for improvement in your practice. And then hopefully you'll also get tools and approaches to implement that change in your practice successfully, and then be able to assess the impact of that change. and hopefully it'll instill a culture that will enable further improvements in practice as people realize it's not as challenging as one might think. That's something we can always tweak our practices in so many different ways that can benefit the physicians and hopefully our patients in the system. Next, please. So the course outline essentially is of 3 webinars spanning a couple of months. So we have a few weeks in between each session. Each webinar lasts about 3 hours. And what we do is combine didactic information about what QI is and how to do it, along with fairly good sized discussion periods. So we have small groups, so maybe 6 or 7, and discussions can be 60, 70 minutes. So it's very helpful to get people thinking about their QI, have their questions answered, and in a fairly collaborative and non-threatening environment. So our colleagues who are helping as facilitators are the group from Ontario MD, and as well as the academic network, the Poplar facilitators. So these are the Primary Care Ontario Practice-Based Learning and Research Network, and within Ottawa it's called the Open Program. And they have facilitators who can also help family docs primarily, and those in that case to look at their data and start looking for potential areas for improvement. So the first webinar really explores the idea of behind QI, why are we doing it? It's an introduction to the model for improvement, and then focusing on data, sort of elaborating on the data driven tool that Mary was alluding to, and it gives you all sorts of different possibilities to explore your data to know how you're doing at the current time. Second session is to start focusing on areas for improvement, but then working through an aim statement, which is the first part of the model for improvement, which is essentially your SMART goals. And after that's been dealt with, then we're looking at specific tools for quality improvement. So once you've identified your area for change, then how you're actually going to make that, test it and to see if it's actually an improvement, and then try to implement it. And in the third session, it's the Plan, Do, Study, Act cycle, which is the main tool for working through a change in your practice, and knowing how to collect the data to figure out how that change is, whether or not it is making an improvement, and then making those changes in your practice that hopefully will be sustainable and of benefit to you, your practice, and your patients. Next, please. So here's a sample agenda. So we try to focus on what's going on in your practices. So we do a number of polls to find out what your major pain points are, for instance, and what are your issues, and what kind of practices you're coming from. Then we have a didactic session where focusing on QI, the why, model for improvement, and data sources. We try to intersperse with the odd video to help reinforce concepts. And we also talk about teams. So most of us don't work in isolation. So if you get a group of people in your practice, your admin, your nurses, other colleagues, to come as work on your project, that can be very helpful. And we talk about that. And then we have a breakout session, which essentially will go through data sources and how to identify those for your particular practice. And then we have homework each time, and then we review the homework after each session to see how people are coming along. So there's a lot of potential for feedback here. Next, please. So one of the first concepts we try to provide you is that quality improvement, you really shouldn't worry. These are methodologies and thinking that you're already likely doing without perhaps calling it quality improvement. For instance, if you've introduced a new EMR to your office practice, if you have gone to a meeting and heard about a new guideline and implement that, those are all QI opportunities. Similarly, the technique for doing QI is much what we do in diagnostics and therapeutics. So you identify a problem, someone's got high blood pressure or new onset diabetes, you measure what's going on, blood pressure, sugars, etc., hemoglobin A1Cs, And then you develop a plan for the individual, what kind of intervention you're going to do, diet, exercise, new medications. So it's all part of the same thinking that we've already been trained in, but it's going to be adapted to a different purpose, which is more looking at your own practice and where you might be able to improve. The other concept is that when we are thinking about quality improvement, we're thinking, well, if I have to improve, that means I'm doing something wrong. Well, that's not what's trying to be messaged here. We're all doing, as Ted had alluded to, I believe 90% of the QA practices assessments were fine. Everyone's doing a pretty good job. But we can always tweak something, whether it's patient flow or new guidelines or whatever. So the implication here is that if you were involved with quality improvement, it's not just you're doing anything wrong, it's just you want to improve what you're already doing. Next, please. So here's the model for improvement. I think this has got an animation, so you may have to scroll through the next one. So model for improvement, again, was developed by the Institute for Healthcare Improvement and starts off by thinking, what are we actually trying to do here? And trying to work through what the aim of your change is, or what your improvement will be, is something that's very important to establish right off the bat. Then once you've established what you're actually trying to accomplish, it's important to identify measures. So how you're going to know something is good or bad, and there are various kinds of measures that can be brought into play in thinking about, we want to see if I've got an idea for a change, how am I going to know that's actually good or not? And then ultimately, what changes can we make to that will result in improvement? It may not be the first time. We may not get that first change. The first change may not make a big difference, or may actually be counterproductive. So it's the point here is to try to think of different ways to improve different changes, and that's something that the tools will be able to help you with. So then once you have some changes to introduce, then you do go through the plan, do, study, act cycle. And that is addressed in our in another session. Next slide, please. Then, here's what happens. So we'll try to do something different. We'll try it, and then did it work or not? And then what's next? Do we keep it, or do we abandon it and then try something else? So that's a section of one of our webinars. Next. Whoops, I think I was missing one. Did we miss one? Anyway, there was one on tools, and the various tools that we use, QI tools for idea generation, and look at root cause for problems that might occur in practice. So anyway, that's in a nutshell the program. 3 hours over three different sessions, and we would be happy for you to participate. So we usually have cohorts of about 50. We had 4 plans so far. They're pretty well all full, and we're looking to introduce another session towards the in the fall. So we hope to have more availability, and then obviously it'll be repeated as the next cohort comes through. So I'll be happy to answer any questions, and much appreciate you hearing about our course. You can either Google us on U Ottawa CPD, or here's the link, and I believe it's also available on the website, or the resources for the CPSO QI program. Thank you.
Dr.
Thanks
Hendry,
very much, Paul.
there's a question in the chat from Jessica Corpus. If this program is mainly for family physicians, or if it applies to other practice areas and specialties.
Yeah, so we've had other specialists involved. Ontario MD has a lot of resources, 20 different dashboards or so that are available for family practices, and a variety of different EMRs. However, we go through all the different data sources and try to troubleshoot with individuals, and do have that opportunity to talk to a facilitator in between sessions to try to find out, if it's a chart-based psychiatry practice, for instance, there may be, as I think Mary had alluded to, there are other ways of getting at your data and identifying areas in your practice that can be followed to see if there have been improvements. So yes, I think there's lots of resources for that, but the vast majority of people who come to our course are so far family physicians. I see some others here. Okay. Does the Ottawa program qualify CPSO cycle? So it's part of, so it qualifies for these CPD programs. So we're accredited. So we provide 9 hours of credits for either Main Pro or the MOC program for the Royal College. So that's just participating in the didactic sessions or in the 3-hour webinars, 9 hours there. If you go to talk to a facilitator, either through Ontario MD or Poplar or CPSO, then all that time you spend in discussing and reflecting on your practice all counts as well. So there are about 34 credits just to participate in the different components for CPSO, another 9 here. And if you do further work regarding talking to colleagues, talking to the facilitators, all that can count too. So it's a very rich program for CPD credits that are embedded in both the Main Pro and the MOC program. Hope that answers your question. Oh, I'm sorry. Yeah, so just for clarification, we aren't the CPSO. So by participating in our program, that doesn't qualify. You still have to do all the modules through CPSO. What our program does is assist you in working through some of that and provide you with a structure to actually enable you to get your goals met.
Having said that, Paul,
Yep.
I imagine that a member who has gone through the U of O program and developed some meaningful and relevant goals could then incorporate those into their practice improvement plan when they get to that section of the CPSO program.
Of course, yes. Well, so it's designed to be able to fulfill the SMART goal requirement for CPSO. Yes. I guess hopefully I'm answering the question. So it's complementary. We are complementary to, not a replacement of the CPSO. So you still have to do all the work through the CPSO portal and complete all the modules. But our program helps, and I believe U of T will be talking about their ideas program too. We provide you with a little bit more on the lingo and the methodology to actually move the SMART goal further along to completion.
Great. Okay, that's great, Paul. And I think it does definitely integrate well with what physicians are required to do with the CPSO program. I think it sets them up to submit and succeed in that. So I think we have around 7 minutes left. We were going to leave this time for some additional questions. April, I don't know if you have some saved or tracked that you want to ask or pose, or if we want to open it up to the attendees.
I think I've answered most of the questions in the chat, but certainly to your point, I would invite anyone who wants to ask a question or feels that they need some additional clarification to raise your hands and we will go in order.
April, just wondering if the issue of walking through the LMS came up in the chat.
It did. It came up from one member. So specific to walkthrough of the portal, there are a few options. We have a recording of our March 2022 webinar available on the Quality Improvement website. And within that recording, there is a guided walkthrough of the portal and how to access each activity as it relates to QI individuals and group subset and partnership. The alternative that we often make available to members as well is everyone is invited to reach out to our program if they would like a guided one-on-one session about how to walk through portal and access activities, particularly if you're experiencing any technological difficulties. I would invite anyone to do that.
And I think we have a slide that illustrates the how to contact us at the CPSO. quality@cpso.on.ca. Those are good people. They have lots of resources to help.
Great. Okay, I think we just have a few minutes remaining, but are there any questions from anyone that's signed in attending that we could help to try to clarify or answer for you?
There's one that just came through Dr. Everson from Dr. Simpson, outlining that they have joined a clinic group recently and was wondering if it would be possible to change my stream from individual to group if I had colleagues interested. So I can answer that one. Absolutely, you can. At any stage throughout the program, you are more than welcome to reach out to us if you'd like to switch from QI individuals to group subset. Or if the band is breaking up, group subset back to individuals, and certainly anyone interested in partnership is welcome to reach out to us if that's an option that their hospital would like to pursue.
Okay, so I guess if there's no other questions, we'll wrap up. So again, thank you to everyone for attending the webinar today. Hopefully you found it informative. As mentioned, the webinar has been recorded. You'll be able to go to our website to access it and view it in the future. And as well, you can always consider viewing our CPSO YouTube page. Would like to again thank our guest, Dr. Paul Hendry from the University of Ottawa.
Thank you.
It's a great program, and it sounds like it will really support physicians doing quality improvement and integrate well with our quality improvement program options. So again, thanks, Paul, for joining us today. And with that, I think we'll wrap up. You have our contact information. Any questions, please visit our webpage under our quality program tab, and then our emails that have been listed. So again, thanks everyone, and enjoy the rest of your day.